Good morning, members, and to the viewing public who are watching today's Ways and Means Committee meeting with folks from Medicaid office through our television live feed and our social media platform. The chair will now call today's order of business to order. With 7 members of the committee on the Standing Committee on Ways and Means present, and we are expecting more members to be present this morning as they are coming shortly. We have the necessary quorum to conduct today's order of business. So with that, we move now to item 2, adoption of agenda. And do I hear a motion? There is a motion to adopt today's agenda, and it has been seconded. Discussion on that motion. Ready? All those in favor, please say aye. Those opposed say nay. Motion is adopted. Moving along in our order of business, we are now on item 3, public comments, and at this time, the chair will open the podium for any members of our public who are here that wishes to provide oral testimony. Podium is open. Seeing that there is no public comments, therefore the chair will now close public comments and move now to item 4, introduction of our members of the Standing Committee. And the chair now will take this opportunity to introduce the members, starting by myself. My name is John Paul Sablon. I'm the chair of the Committee on Ways and Means. To my left is Representative B.J. Atto, vice chair of the committee. To his left, we have Madam Floor Leader, member of the Ways and Means Committee. To her left, we have Representative Joel Camacho. To his left, we have Representative Malcolm Omar. To his left, we have Representative Angelo Camacho. And across the aisle, we have Representative Denita Yangtumai. Also joining us virtually is Representative Julie Ogo. And as I mentioned earlier, we will be graced with some of the members who are on the way here. Assisting our committee on today's order of business are our legal counsel, Joe Bermudez, our fiscal analyst, Mr. Cameron Nicholas. We have our senior legal legislative assistant, Ms. Claire Sablon. We also have our IT, Mr. Dale Martita. We have also our legal Del Camacho, my apologies. We have our Sergeant at Arms, Pete Towai. Also joining us just now is Representative Ralph Yumo. So with that, under item 4, introduction, item A, statement from the chair. At this time, Director Cruz, I'd like to take this opportunity on behalf of the Committee on Ways and Means to thank you and your team, the Medicaid family and your partners who are here to provide us audience with you so that we can discuss the governor's proposal to the legislature on behalf of your agency. So with that, we thank you for coming this morning. Moving along now on our order of business is item 5, new business, and that is under A, the CNMI Medicaid Agency. And this time, I will now give you the floor, Director Cruz, if you can kindly please introduce your team to the body. And I understand that you are going to be providing a presentation to this full August body of the Committee on Ways and Means. I believe every member has the documents provided by your office so that we can follow through. So you have the floor now, Director, please.
Thank you, Mr. Chairman. Before we begin, I'd just like to introduce our team that's here. In addition to a lot of our other team behind us who are supporting us, to my right, we have Ms. Hilma Castro, who is our Acting Program Integrity Manager. We have Mr. Roman Tadella, who is our Senior Policy and Program Analyst. And to my left, I have Ms. Vicenta Rosario, who is our Administrative Manager. And to her left is Mr. Vince Castro, who is our Medicaid Enterprise System, or MES Manager for our Medicaid agency. So again, Hafide, and good morning, Mr. Chairman and members of the committee. Again, my name is George Cruz, and I am the Director of the Commonwealth Medicaid Agency within the Office of the Governor. Thank you for the opportunity to appear before you today to discuss the Commonwealth Medicaid Agency's fiscal year 2027 budget. But before I discuss the numbers before you today, I believe it's important that for this committee and for the people of the Commonwealth to understand where the Commonwealth Medicaid Agency was approximately 20 months ago, where it is today, and where we are working to take it. Because the numbers of a budget document don't tell that story. The transformation does. When I came into the Commonwealth Medicaid Agency 20 months ago, I did not walk into an agency that simply needed additional funding. I walked into an agency that needed to be rebuilt. The majority of our processes were 100% manual. The majority of the paperwork was everywhere, on desks, in offices, in file rooms, and in banker boxes stacked throughout the agency. Files were overflowing, and in some areas, boxes were literally lining hallways. Our physical environment was old, gloomy, and quite frankly, uninspiring. The workplace itself did not reflect the importance of the mission we were asking our employees to perform every day. Even something as basic as parking was a daily challenge. Staff parking was difficult, but beneficiary parking was even more difficult. Finding a place to park sometimes felt like playing Tetris with vehicles, trying to maneuver cars into whatever space was available. But those physical conditions were only a symptom of a much larger problem. The real challenge was operational capacity. Our eligibility section was significantly understaffed, and attempting to serve more than 100 clients a day while simultaneously working through application verification backlogs that were averaging 3 to 4 months. Our beneficiary enrollment function had essentially one person responsible for processing and certifying thousands of Medicaid application requests, with a backlog that had reached approximately 6 to 8 months or more. Our claims section was dealing with thousands of claims coming into the agency every single day, with much of the work being performed manually. The claims operation had also become highly siloed. Staff were often limited in their ability to assist one another or respond to provider questions because the system and processes were not designed to allow information to flow efficiently across the organization. And then there was the claims backlog. The agency had accumulated approximately 5 years of unadjudicated claims, representing more than $40 million in potential economic activity for the Commonwealth's healthcare providers. These weren't just numbers sitting on a computer. These were claims for healthcare services that had already been provided. Then we had our compliance and prior authorization function. At one point, we essentially had one person handling hundreds of prior authorization requests while simultaneously trying to address thousands of older authorizations dating back as far as 2020. That created an unfunded liability to the agency of more than $50 million in potential payments to providers for, again, services already rendered. And that same function was also responsible for coordinating care for approximately 100 Medicaid beneficiaries receiving medical treatment off island. That is not simply a workload problem. That is a system capacity problem. And then there's the system itself. Our Medicaid enterprise system modernization effort was also in a significant disarray. For approximately 12 years, the Commonwealth had invested more than $20 million in subject matter expertise and project management resources. Yet, when we assessed where we were, we had very little tangible infrastructure to show for that investment. We did not have comprehensive SOPs in place. We did not have the operational systems we needed. We did not have integrated processes that we needed. And more importantly, we had not achieved the level of modernization and operational transformation that the Commonwealth had invested in and expected. At the same time, the organization structure of the CMA was largely based on an organizational chart that had been established since 2001. Think about that for a moment. An organizational structure designed more than 2 decades ago was still being asked to support a modernized Medicaid program. Since 2001, healthcare has changed. Our beneficiary population has changed. The number and complexity of Medicaid applications have changed. Provider participation has changed. Healthcare services also have changed. Technology itself has changed. And yet our organizational structure had not fundamentally evolved with those changes. But that is not where we are today. And that is where I want to be very clear with the committee today, Mr. Chairman, is I am telling you this history not to criticize the agency. I am telling you because you cannot evaluate where we are going unless you understand where we started, or at least where I started. Over the past 20 months, our team has been rebuilding the CMA, not simply maintaining it. We have been moving from paper to process, from silos to collaboration, from manual work to modernization, from backlogs to accountability, from reactive operations to structured management, and from an organization that was primarily trying to keep up with the workload to an organization that is beginning to anticipate the Commonwealth Medicaid's program we need next. We have been attacking the backlog. We have been restructuring functions. We have been strengthening provider enrollment. We have been improving eligibility operations. We've been addressing prior authorizations and medical review. We have been rebuilding our policies and procedures. And we have been working with CMS to identify federal opportunities that can bring additional resources into the Commonwealth. And we are modernizing the Medicaid enterprise system so that the agency can eventually operate as a modern Medicaid organization rather than a paper-driven government office. And so this brings us to the budget which is before you. With that context I just shared with you, I want to make our position clear. We are aligned with the administration's Scenario 1 budget submission for the Commonwealth Medicaid Agency in the amount of $5,648,237. We recognize the broader fiscal challenges facing the Commonwealth, and we appreciate the work of OMB, Department of Finance, and the Governor in balancing Medicaid alongside the many other priorities of this government. Our purpose today is not to focus on what CMA does not have. Rather, we want to show the committee what the Commonwealth investment in Medicaid is accomplishing, where the program is headed, and the additional opportunity that exists when local resources are available to leverage federal Medicaid funding. So, just to give some context to our budget, the CMA submitted our original fiscal year 27 budget request in February based upon the federal allotment information that was available to us at that time. That original submission reflected a local reimbursement need of approximately $5.5 million. However, CMA does not receive its updated annual federal allotment until later within the year. We subsequently received our updated fiscal year 27 allotment, federal allotment, increasing CMA's federal allotment to approximately $111 million. That is nearly $4 million increase over this current fiscal year, which is about $107 million. With that increased federal allotment, of course, comes an increase in local funding requirement. Based upon the financing structure currently available to us, the CMA estimates that approximately $7.92 million in total local support would be required to fully utilize the federal funding opportunity available to the Medicaid program. Therefore, the difference between our February submission of 5.5 and the amount we are discussing today does not represent a change in our direction in supporting Scenario 1. It reflects updated federal information that became available after our original budget request had already been submitted. The administration's Scenario 1 provides approximately $5.64 million in overall matching support for the CMA. Given the Commonwealth's current economic condition, the CMA supports, again, Scenario 1. We view this as the minimum responsible level necessary to maintain healthcare funding operations and to continue the major efforts that we are already implementing. At the same time, we believe the committee should understand the opportunity, though what remains. Scenario 1 leaves an estimated $2.28 million gap between the local funding provided on Scenario 1 and the amount necessary for us to be fully maximized. Because Medicaid is a matching program, that local difference has substantial larger impact. Based upon our current estimates, the $2.28 million local gap could affect approximately $11 million in federal matching funds that the Commonwealth otherwise has an opportunity to utilize. Scenario 2, which we don't want to go, definitely creates an even larger gap. Under Scenario 2, which was presented to you, the local reimbursement funding would be approximately $5 million, leaving a shortage of approximately $2.92 million and potentially affecting over $14.5 million in federal Medicaid funding. So we provide these numbers not to characterize each scenario as a failure. We provide them to show the committee that the return that Medicaid can generate from local investment. And to emphasize this point, when we talk about leveraging federal Medicaid dollars, we are not talking about money that simply sits inside the Commonwealth Medicaid agency. It moves. It moves into our healthcare system. It moves into our hospital. It moves into our physicians' offices and our pharmacies, and it moves into medical suppliers and off-island specialty providers. And ultimately, it moves through the CNMI economy. As of July 2026, this fiscal year, the CMA has provided more than $59.4 million on-island payments alone, and approximately $16.4 million on off-island payments. And following the two Category 5 disasters, the CMA has also provided approximately $11.7 million in financial disaster support. These are not simply government expenditures. These are healthcare dollars circulating through the Commonwealth. Today, the CMA is supporting approximately 23,690 active Medicaid beneficiaries, approximately 56% of the entire CMI population. And as you can see, which is on your screen, earlier it was showing on the third paragraph that when we first started this fiscal year, we were at 53%. That has increased additional 3%. So this represented an increase of approximately 58.5% since the beginning of fiscal year 2026. So when we talk about Medicaid funding, we are not talking about a small government program servicing a small segment of our population. We are talking about a program serving more than half of the people who live in the CNMI. And with the reduction in hours, anticipated furloughs, and other potential workforce reductions in fiscal year 2027, the CMA anticipates that the pressure on the program and potentially the number of people relying upon Medicaid could increase substantially. So, Mr. Chairman and the members of the committee, this is the picture I want you to have when you look at the CMA budget. 20 months ago, we were dealing with paper files, years of backlogs, manual processes, inadequate staffing structures, fragmented systems, millions of dollars in unprocessed claims and prior authorizations, and an organizational structure that had not fundamentally changed since 2001. Today, we are rebuilding something different, and we are not finished, and there's still a lot to be done. There is still a tremendous amount of work ahead of us, but we are no longer simply asking How do we keep up? We are now asking, how do we build a Medicaid agency capable of servicing the Commonwealth for the next 10, 20, and even 30 years? That requires investment. It requires systems, people, requires accountability, and it requires the Commonwealth to recognize that every local dollar invested in Medicaid has the potential to leverage substantially more federal resources. That is what our team would like to demonstrate to each of you today. You will hear about the beneficiaries we are serving and the level of activity required to maintain that coverage. You will hear about the financial side of the program and how local appropriations help unlock federal participation. You will also hear this morning about our Medicaid enterprise system modernization and how we are moving from legacy and manual processes. You will also hear about the policies, the medical review functions, provider oversight, and internal controls we are building to strengthen accountability. And you will also hear about the work we are doing directly with our federal counterparts to secure new opportunities for our providers and our beneficiaries. From disaster-related support to long-term strategies intended to expand health care access and make better use of the resources available to the Commonwealth. They will show you the numbers. They will show you the workload. They will show you the improvements. And they will show you what remains to be done. But I want to begin by giving you something that a spreadsheet cannot provide, and that's context. Because the CMA budget before you today is not simply a request to fund our agency. It is an important investment in the transformation of an agency that serves more than half of the Commonwealth. We support Scenario 1. We recognize the fiscal realities facing the Commonwealth, and we at the CMA are willing partners in ensuring accountability and being good stewards of public funds. And if additional resources become available during the legislature's deliberations, we respectfully ask that Medicaid be considered as an area where that additional $2.28 million in local investment could potentially leverage approximately $11 million more in federal resources. Scenario 1 protects our baseline, but additional local investment expands our opportunities. And our commitment is to make sure that every dollar entrusted to the CMA produces the greatest possible benefit for the people of the Commonwealth. And with that, I would like to begin with the people at the center of this program. I'll turn over to our eligibility and enrollment team to provide the committee with a picture of who the CMA is serving today and the level of work required behind the scenes to make sure those people remain covered.
All right. Good morning, Chairman and members of the committee. My name is Roman Tadella, and I serve as the Senior Policy and Strategic Initiative Analyst with the Commonwealth Medicaid Agency. Now, I'd like to take a few minutes to highlight the scale of the population that our eligibility and enrollment team is currently serving and why it matters as we look at CMA's budget and modernization efforts. As of today, as mentioned by Director, CMA is supporting approximately 23,690 active Medicaid beneficiaries. And to put that growth into perspective, in October 2025, at the beginning of this fiscal year, we had approximately 14,946 active beneficiaries, an increase of approximately 58.5%. And I think that growth is important to understand because eligibility isn't just a one-time transaction. So when someone becomes eligible for Medicaid, our responsibility doesn't end once they're enrolled. Our team has to continue maintaining those records, processing renewals, reviewing documentation, responding to household changes, and making sure that eligible beneficiaries are able to maintain continuity of coverage. So as our beneficiary population grows, the workload behind maintaining that coverage also grows with it. And that's where the eligibility and enrollment team connects directly to the modernization work that you hear about from our Medicaid Enterprise Systems team. So we are now managing nearly 24,000 active beneficiaries along with the thousands of renewals or of other eligibility actions throughout the year. And at that level of activity, we need systems and staffing that can manage the volume accurately and efficiently. Our mass modernization efforts give CMA an opportunity to strengthen that infrastructure. It can help us improve how we track applications and renewals, reduce our dependence on manual processes, support more consistent eligibility determinations, and give our staff better visibility into where a case is within the process. And for our beneficiaries, that means working towards an enrollment and renewal process that is more timely, more reliable, and easier to navigate. For our staff, it means having better tools to manage a growing workload. And overall, for the Commonwealth, it means building the capacity needed to responsibly manage a Medicaid program that is now serving more than half of our population. So when we talk about investing in eligibility and enrollment and modernizing the systems behind it, we are really talking about protecting access for the 23,690 beneficiaries who currently depend on this program and making sure that CMA has the capacity to continue serving them well as the responsibility grows. And so those enrollment figures show the people behind the Medicaid program. The next question is how the Commonwealth's investment translates into the federal funding and healthcare resources available to serve them. And so with that, I'll turn it over to our administrative division to provide that financial perspective.
Good morning, Chairman and members of the committee. As the Administrative Services Manager overseeing the overall finances of the agency, I want to provide a general overview of the agency's submission and the impacts of underfunding the Medicaid program. In fiscal year 2026, the CMA received over $107 million in federal allotment, in which Public Law 2414 sufficiently funded the local match with the $6.2 million appropriation. However, Public Law 2420 revised appropriations reduced CMA's budget to $4.6 million. By the end of this fiscal year, the CMA is expecting to return a little over $10.8 million in unspent federal funds due to the shortfall. CMA's revised fiscal year 2027 total budget request is $7.9 million, which reflects actual federal allotments expected. This is an increase from the originally submitted package at the end of February because the actual federal allotments are not available around that time, and therefore estimated amounts were applied. Additionally, further revisions were made to best align with the governor's revised proposal submitted in July. The $7.9 million represents the total local matching funds needed across all federal funding sources. While we are aware of the CNMI's financial state and are willing to work within what we are allowed, I want to make you all aware of the risks and the impacts of underfunding the Medicaid program. The lifeline of Medicaid is in your hands. When government employees can no longer afford their Aetna premiums due to furloughs or reduction in hours, highly most likely they will be coming to Medicaid seeking assistance. And highly most likely they will be eligible and further increase our Medicaid population. The Medicaid program offers the Medicare buy-in, where CMA pays for the premiums for eligible Part B beneficiaries. When the Medicaid program runs short of local match and is unable to pay its share of these beneficiaries' premiums, they will ultimately fall back in the hands of our beneficiaries. These beneficiaries may be your mom, your dad, your grandparents. Now let's talk about access to care. When the Medicaid program does not have the sufficient local match to draw down any more federal funds to pay our providers, they will not get paid. When they don't get paid, either services will be reduced or possibly even shut down their business. When their business shuts down, not only is access to care limited, now more people will be left without jobs. The investment in our providers is an investment to the CNMI. These same providers pay taxes and contribute to the CNMI economy. When providers shut down their businesses, not only does it impact access to care, but it further increases poor health outcomes, which will result in an increase in off-island medical referral services because it'll be too late and specialty care will be required. When we run short of local matching funds and unable to pay our off-island providers, we further reduce access to specialized care unavailable in the CNMI. Many years back, the Medicaid program lost many providers due to non-payment, both on and off-island. Because of that, today we continue to be challenged with securing an alternative laboratory provider. Because of that, we only have one contracted laboratory, and that is the hospital. Because of that, we are forced to seek off-island laboratory service providers. Over the years, we have made significant improvements in our claims reimbursement turnaround time, reducing the processing period from up to 12 months to approximately 90 days in most cases. This represents a substantial improvement in efficiency and demonstrates our continued commitment to faster, more predictable, and more responsive claims resolution. While we are working so hard to reestablish our relationships and further expand our provider network, we are yet again faced with the risk of non-payment. I can go on, but I think you know where I'm going with this. Again, we are mindful of the CNMI financial state, but I will continue to advocate not just for over our 20,000 beneficiaries, but for our providers as well. The opportunity to invest in the Medicaid program is here. It has been here. More beneficiaries means more money. More federal funds means more money. More negative health outcomes means more money. I respectfully ask that as you deliberate on the fiscal year 2027 budget, you recognize that funding Medicaid is not simply an appropriation. It is an investment in the health, stability, and future of the CNMI. The decisions you make today will directly affect our beneficiaries, our providers, our healthcare system, and ultimately the entire community. We are asking for the resources necessary to sustain the program, protect access to care, and maximize the federal dollars available to the Commonwealth. The lifeline of Medicaid is in your hands. And maximizing those resources also requires us to improve the infrastructure behind the Medicaid program. I'll turn it over to our Medicaid Enterprise System team to explain the modernization work underway and what that investment can mean for the Commonwealth.
Chairman and members of the committee, my name is Vince Castro, and I am the Medicaid Enterprise Systems Manager, and I'd like to briefly update you on CMA's Medicaid Systems Modernization. This is simply not just a technology project. The systems we are improving to support is everyday work of Medicaid, how we determine eligibility, process information, support provider payments, protect public funds, and meet federal requirements. One of our major accomplishments is that CMA has already secured CMS authorization for approximately $18.3 million in modernization activity, including $15.9 million in federal funding and approximately $2.4 million in territory share. Our original implementation schedule has moved by approximately 1 year because specialized procurement, contracting, federal review took longer than initially anticipated. We recognize that, but the schedule moving does not mean that the need for modernization goes away. CMA still relies heavily on legacy systems and manual processes. Our modernization effort is designed to strengthen 4 basic areas: eligibility and enrollment, claims and provider payments, federal reporting, and program integrity. Our next step is to complete the necessary contracting actions, update our implementation schedule with CMS, and move the work forward in manageable phases. There is also an important issue we want the committee to understand. Before the administration's proposal reached the legislature, MES's operations funding was zeroed out. That funding was intended in part to provide the local support needed for vendor implementation payments. We understand that fiscal decisions that had to be made in developing the overall Commonwealth budget. At the same time, restoring some level of the MES operation support represents an opportunity. It can help CMA move federal authorization from planning to implementation. That means less dependence on paper and manual processes. It means better tools for our staff. It means stronger information, more reliable operations, and better support for beneficiaries and providers. With that local support, modernization does not disappear. We will be moving forward, but implementation may need to proceed more slowly, which means CMA may remain dependent on legacy and manual processes longer than necessary. So our message to the committee is simple. The schedule moved, but the need did not. Additional local investment would help CMA turn an already approved federal opportunity into actual improvements for the Medicaid program. Modernizing our system is one side of building a stronger Medicaid program. The other is making sure the policies, decisions, providers, and internal controls behind those systems are equally strong. And with that, I'll turn it over to our Policy and Regular Affairs.
Good morning, Mr. Chairman and members of the committee. Again, my name is Hilma Castro, and I am the Acting Program Integrity Manager. The Office of Policy and Regulatory Affairs is focused on strengthening the accountability structure behind the Commonwealth Medicaid Agency's operations. As the CMA modernizes, we also have to make sure that the decisions we make, the providers participating in the program, and the controls governing the agency are consistent, well-documented, compliant, and defensible. Our work is currently concentrated in 3 areas. The first is with the Medical Services Review Unit. This section is being developed to establish a more structured and consistent process for evaluating medical services and determining whether requested care meets Medicaid coverage and medical necessity requirements. Our immediate priority for this section is staffing, which as of this time, it is currently unfilled. We are also working towards standardizing procedures, review tools, documentation requirements, and consistent processes for authorization, reconsideration, and appeal support. The objective is to support timely access to medically necessary care while also making sure that Medicaid resources are protected from services that might be duplicative, unsupported, or inappropriate. The second area is with Provider Relations and Compliance Unit, otherwise known as Provider Enrollment. The CMA is strengthening how providers enter and remain in the Medicaid program. This includes improving screening and revalidation, updating provider agreements and application materials, moving toward electronic provider enrollment, and strengthening our ability to identify potential compliance or program integrity concerns. At the same time, provider enrollment is working with other sections to identify service gaps and expand the provider network available to our beneficiaries. Currently, we have 40 providers enrolled within the CNMI, 9 in Guam, and 8 in California. The third area is with our newly established Regulatory Affairs and Internal Control Unit. This unit is building a centralized structure for tracking regulatory requirements, policies, risks, audit findings, corrective actions, and federal deliverables across the CMA. It will allow leadership to see where issues exist, who is responsible for correcting them, and whether those corrective actions have actually been completed. This work may not always be visible to a beneficiary walking into our office or a provider submitting a claim, but it is essential to a well-run and compliant Medicaid program. It helps the CMA catch issues earlier, improves consistency, prepares us for audits, and reduces repeat audit findings. It also demonstrates responsible stewardship of both federal and local funds. So this investment is not simply about adding administrative functions. It is about building the internal structure that protects everything else the CMA is trying to accomplish. Our goal is straightforward: better decisions, stronger accountability, and greater protection of the Medicaid program and the people it serves. While Policy and Regulatory Affairs strengthens the program internally, another important part of the CMA's work is looking outward, working directly with our federal partners to identify new authorities and opportunities that respond to the unique needs of the Commonwealth. And with that, I'll transfer it back to Roman.
Thank you, Hilma. So at its core, our Federal Programs and Grants Division serves as one of CMA's main points of coordination with the Centers for Medicaid and Medicare Services, or CMS. And what that means in practice is that we take the needs we're seeing here in the Commonwealth and work directly with CMS to determine what federal authorities, state plan changes, waivers, or funding opportunities may be available to help us respond. And so for some context, I joined CMA in March, so about 5 months ago, and almost immediately we had to put boots on the ground following the 2 super typhoons and the declarations of public health emergencies that followed. And so from March through July, we worked very closely with CMS to develop and submit 4 disaster relief state plan amendments, all of which have since been federally approved. And so those approvals gave us temporary flexibilities that were very practical for our community. For our beneficiaries, that included things like emergency prescription refills, replacement medical equipment and supplies, temporary eligibility flexibilities, and access to disaster-related behavioral health services. And for our providers, it also gave CMA additional flexibility to support payment and maintain healthcare services during the recovery period. Altogether, those disaster relief SPAs created authority for up to approximately $11.7 million in disaster-related support. And I think that's an important example of what our partnership with CMS can accomplish. When we can clearly identify a need here at home, develop the right federal pathway, and move quickly with CMS, we can bring additional support back to the Commonwealth. And one of the biggest examples of that is our Disaster Interim Payment Program, or DIP. So during a disaster, our providers can experience interruptions in operations, billing, or cash flow. And unfortunately, that can happen at exactly the same time our community needs healthcare services the most. And so through DIP, CMA received temporary authority to provide qualifying Medicaid providers with interim payments based on their prior Medicaid activity or other reasonable estimates, which amounted a capability of over $4 million of covered services during the public health emergency. And with that, the goal was simple. We wanted to help providers maintain their operations and continue caring for our beneficiaries while normal billing and payment processes recover. At the same time, there are safeguards built into this DIP program. Providers must be enrolled and in good standing with CMA. They have to demonstrate that they were impacted by the disaster, and they can be under an active program integrity investigation or payment suspension. And so those payments are also reconciled later against actual allowable claims, and any overpayment has to be returned back to CMA and to CMS. So DIP is not simply an advance payment. It is a controlled provider stability tool that helps us protect access to healthcare during an emergency. However, as I've been talking about a lot of disaster-related support, our work doesn't stop with just that. We've also been looking ahead through what we are developing as CMA's broader policy access strategy. A major part of that strategy is our work towards a permanent foreign provider state plan amendment. One of the realities that we deal here in the CNMI is our geographic isolation and our limited access to certain specialty services. And so when those services are not available locally, our beneficiaries have to travel off-island. And I want to be clear, our goal isn't to replace or diminish the quality of care that our beneficiaries are currently receiving through our existing referral jurisdictions. What we want to do is we want to expand the window of options available to them. A permanent pathway to qualified foreign or regional providers could give CMA more options when deciding where medically necessary specialty care can be delivered appropriately and cost-effectively. And for the beneficiary, that could mean more choices and potentially receiving care closer to home. For CMA, it could also give us an opportunity to better manage the overall cost of off-island care, including travel and other related expenses. And if we can use those resources more efficiently, we may be able to stretch our Medicaid dollars further and serve more beneficiaries. That is why we see the foreign provider SPA as both an access strategy and a sustainability strategy. But that's not simply the whole piece of the work. We are also advancing the development of behavioral health services, building on what we learned during the disaster response and looking at how we can create a more permanent pathway for those services. We have also received approval for our non-emergency medical transportation state plan amendment because having Medicaid coverage only goes so far if a beneficiary cannot actually get to the care that they need. We are also in discussion with CMS around new certified public expenditure opportunities. This is where we are looking at whether public healthcare expenditures already taking place within the Commonwealth can be structured in a way that supports additional federal Medicaid participation. And we also continue to explore our Section 11 demonstration waiver that can support broader innovation in access, service delivery, and financing. And so when you put all of those efforts together, they really represent one overall strategy: expand access, create more options, strengthen our providers, and use our federal Medicaid partnership more effectively for the Commonwealth. We are going to continue working directly with CMS to open these opportunities, but federal approval by itself doesn't implement a program. At some point, these initiatives still require people, operational capacity, and in many cases, the local investment necessary to access and sustain federal participation. So I think the best way to describe the role of this division is our job is to help open the federal doors, and the Commonwealth's local investment is what allows CMA to walk through those doors and turn those opportunities into real healthcare access for our providers and our beneficiaries. And with that, I'll turn it back to our director to bring together what those efforts mean for CMA's overall budget request.
Thank you, Roman. So, Mr. Chairman and members of the committee, on behalf of the Commonwealth Medicaid Agency, I want to thank you for the opportunity to present our fiscal year 27 budget, and more importantly, to show you the work that is taking place across the agency. I hope today's presentation has demonstrated that the CMA is not standing still. We are rebuilding, we are modernizing, and we are moving forward. Today, we are serving more than 23,000 active Medicaid beneficiaries, representing approximately 56% of the entire CNMI population. But the significance of Medicaid goes beyond the number of people we cover. It goes beyond the walls of the CMA. Medicaid is one of the Commonwealth's most significant healthcare and economic engines, and the numbers demonstrate that. In fiscal year 23, the CMA paid approximately $83 million in Medicaid reimbursements. In fiscal year 24, that increased to more than $86 million. In fiscal year 25, the CMA paid more than $120 million in reimbursements. And for fiscal year 26, we are working toward approximately $100 million in total reimbursements this fiscal year. That represents approximately $389 million in Medicaid reimbursements over these 4 fiscal years. Think about that. Think about what that means for the Commonwealth. That approximately $389 million flowing into our hospitals, physicians, pharmacies, medical suppliers, behavioral health providers, specialty providers, off-island providers, and other healthcare services. Those dollars pay employees. They purchase medical supplies. They support businesses. They support families. They support healthcare infrastructure, and they circulate through our local economy. Medicaid is not simply an expenditure of government. It is an investment that returns resources to the Commonwealth's healthcare system and economy. And that is why the work we have undertaken over the last 20 months is so important, because we are not simply trying to keep the agency operating. We are rebuilding the infrastructure necessary to manage this program for the future. We have substantially reduced the prior authorization backlog from more than 5 years accumulated work to less than 1 year. Our goal is not simply to catch up. Our goal by the end of this fiscal year is to reach real-time prior authorization processing. That means a provider should not have to wait months or years to receive the determination necessary to provide care to a Medicaid beneficiary. We have also just closed the RFP for a modernized eligibility and enrollment system that will fundamentally transform the customer experience of our beneficiaries. That system itself is intended to reduce administrative burden, improve processing efficiency, accelerate eligibility determinations, and allow individuals who qualify for Medicaid to receive a determination coverage more quickly and more timely. Again, this is not simply an IT project. This is a healthcare access project. It means a mother should not have to wait months to know whether her child has coverage. It means a senior, a monomco, should not have to navigate paper-driven process to maintain their health care. And it means our staff should be spending less time moving paper and more time helping people. And it means the CMA will finally have the technology infrastructure necessary to manage a modern Medicaid program. These are just some of the steps we are taking to rebuild the agency. And that brings us back to the fiscal year 27 budget. The CMA's fiscal year 27 federal allotment is $111 million. To fully utilize that federal opportunity, our current financing structure requires approximately $7.92 million in local funding support. Again, the administration scenario 1 provides approximately $5.64 million, which the CMA supports scenario 1. Again, this is our minimum responsible level necessary to maintain our healthcare access for our beneficiaries. But I also want to again be very clear. Scenario 1 is the floor, not the ceiling. But the additional $2.28 million would allow the Commonwealth Medicaid to maximize the $111 million in federal Medicaid funding available to us now. Based upon current estimates, that additional $2.28 million in local investment could allow the Commonwealth to access approximately $11 million more in federal Medicaid funding. That is an extraordinary potential return. And there is something else I believe this committee should recognize. Historically, the Commonwealth Medicaid Agency has never been fully funded to maximize the federal Medicaid funding available to it. We have operated with constraints, we have made adjustments, we have prioritized, we have carried backlogs, and we have relied heavily on our employees to do more with less. And despite these limitations, the CMA has continued to put tens and now hundreds of millions of dollars into the Commonwealth's healthcare economy. So the question before the legislature is not simple. I know that, I understand that. And it's not simply how much money does the CMA need. I believe the better question is how much federal healthcare investment does the Commonwealth, the CNMI government, want to bring home? Because the additional $2.28 million is not simply another $2.28 million in government spending. It represents the opportunity to leverage approximately $11 million more. That means more resources flowing into our healthcare providers, more resources supporting healthcare services, more resources supporting our beneficiaries, and more resources circulating through our economy. We appreciate administration's support, the committee's consideration, and your continued partnership in helping us strengthen the healthcare access for the people of the CNMI. Thank you, and I yield back our time.
Thank you, Director Cruz and your team. Before we enter into questions and answers, let me recognize the presence of Leader Roy Adda, who is also a member of the Committee on Ways and Means. And also assisting this August body is Ms. Jasmine Camacho from the Office of Management and Budget. So let's start with questions and answers, and the chair will start. I know that your presentation with your team, Director Cruz, spoke about supporting scenario 1 at the 5.5 plus million. So with that scenario, that only represents 100 million of federal grants that we are supposedly to receive, because there's an additional of 11 million that was granted by your grantors, but that will require us additional 2.8 million. Is that correct?
Yes.
And then with this 111 million, how long within the fiscal year can we find the local state can find the money for it? Let's say, for example, for now, since the governor is proposing 5.5, and down the pipeline, if we can realize the additional 2.8, is it possible that we can appropriate that so that we can leverage and maximize the additional 11 million?
Yes.
So
Answer,
that your
yes.
grantors allow us all through the fiscal year. Is there a deadline for it to achieve the ceiling?
Well,
I think it's important for this body to understand that.
yes, definitely. We have all the way to the end of the fiscal year to process payment reimbursements. So once that is done, all the way up until, I believe, the end of the fiscal year, we can access that federal funding.
So your grantors are following the fiscal year.
Correct.
Budget year. So that's October 1st to September 30th of next year.
Correct.
Okay, thank you for that response. You spoke about a lot about backlogs, and I think it's important to kind of dive into that, and maybe perhaps not on your leadership, right? The previous leadership, there are major backlogs. Are you saying that those backlogs from many years ago, Medicaid office are now getting reimbursements? Because I think the time frame for Medicaid to process reimbursement is, I think, from a month to 12 months, right? Anything after that, is it a loss for our agency, or we can still, argue the case, anything that's over a year?
So based on my experience this past 20 months, anything that's still pending, as long as the services were provided during the time frame, and even though we did not pay it out at that time because of our backlog issues, it's still covered. It just carries on to the next fiscal year.
So,
And
so despite 2 years past, you're still getting those reimbursements,
we are still paying those reimbursements, yes, those invoices.
but you're getting those approved by the grantors from the previous.
So those invoices are submitted back during those times of services that were provided. They're not billing us now for services 5 years ago. We received those invoices, it's just we never processed them.
Okay, so is there a deadline for processing these reimbursements? Is what my ultimate question would be.
So as long as the providers submit the claims within the 1 year service, then we can carry it over as long as we need to.
So 1 year is the time frame,
For the providers to submit, correct.
and then what is the other?
We have that
Timeframe.
flexibility.
And that's
We
what's
can
the
carry
time
it
frame for
over.
that?
There's no deadline.
No deadline. Okay, that's great to know.
The only, just if I can add clarity to that, Chairman, is one of the things when I came on board was we needed to balance our budget with Medicaid. And so, like I mentioned earlier in my testimony, that we had a lot of unfunded liabilities. And so if we didn't take care of all this backlog, the only thing, the 111 million or 107 for this fiscal year was not just covering services for this fiscal year, but it was eating into all of the other services that we did not pay for, right? And so we were always, that's the reason why many times too, we were always short, because without managing our the budget and paying off all of our previous liabilities, it kept eating into the next fiscal year's
Okay.
budget. And so
Okay.
that's our goal, and we're
Right.
almost there. We literally are. Like I said, we were about 5 years back.
Okay.
Now we're literally within 1 year's
Okay.
worth.
Now that paints a clearer picture on how you guys are able to get on top of those backlogs. Thank you for that response. And then let me move to the 11.7. I want to congratulate you guys for getting that award of the financial disaster support. So what is our time frame to kind of take advantage of this 11.7 for disaster support that you guys are awarded?
So we just, the bill was just actually passed in the Senate, the U.S. Senate, and is now being reviewed in the U.S. House. We are currently using our funding, our available funding to manage those disaster payments. The good thing is, once the president signs the legislation in the U.S. Congress, the language in there says until expended. So as long as any services are provided within, between April 1st of this fiscal year until September 30th, and that additional funding, the 11 or 20, actually we have 21.4 million that the U.S. Congress is working on providing to the CMA for strictly disaster-related services. We can utilize that and spend that down throughout the years.
So no fiscal limitation is
Correct.
what you guys were told. And so in totality, it's actually 21. So where do we get the 11.7? So, and then it's not even passed yet in the Senate, but you were told by your grantors that the likelihood that we will get is that the minimum 11.7. Is that what you're
So,
presenting to this body?
yes, so this fiscal year, our federal allotment was $107 million. And so it got increased to 111. And so out of the 111, what we're looking at is if we don't have our full federal local match, then we would have to return $11 million out of the 111 that was allocated
Right,
for the
right.
CNMI.
Right.
So that's what we're talking about. In addition to the 111 million, the U.S. Congress is working on additional $21.4
For
million
disaster.
for the disaster to help us with Saipan, Tinian, and Rhoda.
Okay. Over the years, Director, thank you for that response. Over the years, I know that you mentioned through your presentation, right, that the state government hasn't been fully maximizing the full ceiling of whatever's awarded to CMA. But during those trends, whenever we don't achieve the ceiling, are we getting less every fiscal year because we don't achieve whatever's been increased? Is that an impact? What are the kind of adverse impact if we don't meet those threshold or the ceiling, right? If we don't take advantage of those ceilings, do we expect next year we're getting 111 for this fiscal year, which is great. There's an increase of 11 million, but if we don't maximize or we don't provide the local match, are we expecting by next fiscal year that we're going to get less in that regard, or what? So my question would be, what is the experience for the past 4 to 5 years with
Okay,
regards
so
to increases?
I can speak on behalf of our
Please.
Medicaid funding. So our 1108 funding is subject to increase every year no matter what. That is statutory. When they made the $60 million federal allotment permanent during the Consolidated Appropriations Act of 2023. But if you look back in history, Medicaid's funding was approximately $7 million
Right,
block grant annually at a 45-55% match.
Right.
And compare where we are today with 83% match instead of the 55%, with $60 million. So when prior leadership went out with along with the other territories to fight for an increase in our federal funds, we got it.
okay.
And so, it's not about the risk of losing additional federal funds. It's more about demonstrating the fight that we did to increase that federal funds.
Right, okay.
So just to give you another example, Chairman and Committee, so one of the things we are working with our delegate, Congresswoman King Hines, is we're looking at wanting to increase our Medicaid funding match. Because right now we're part of the 111 million. Our Medicaid program funding source is about $72 million, 72 point some million dollars. And we are the lowest amongst all the territories. American Samoa, with the same population that we have right now on just Medicaid alone, receives about 97 million. So we have there's a $30 million gap of inequity between the two territories with the same population. And so, of course, our thing is it's a double jeopardy for us, because if we continue with this advocacy with the Congresswoman to say, hey, we need to get up to 97 because we have the same population, we have the same needs, et cetera, but then why fight for that and get that, which can improve our economy, improve our healthcare system, but we can't maximize it, right? And because of the local match. And so just want to put that into perspective as well.
Okay, let me just recognize the Vice for a follow-up on the questions.
Thank you, Chairman, and thank you guys for being here this morning and making your presentation. It's a really good presentation. The $22 million, that's a separate appropriation, correct?
Yes.
So can we use that as part of the matching?
No. As our local match?
As
No.
a local match?
And the only reason why is because the 21.4 million is supplemental strictly for the disaster services.
Okay, but the disaster services is that appropriation is without fiscal year limitation, right? So if it goes on for 5 years,
Well, it's only for services that are provided within April 1st to September 30th of 2026.
So that would mean that the money would lapse out after September 30th.
So again, the language states that it's until expended. So that means because as long as the services were provided within that time frame due to the disaster, and providers submit their invoices to us, and let's say because of our current backlog situation, we don't pay it out until January 2028, those funds would still be
Okay.
available for us to use to pay those off.
So the providers, how quickly do they provide, or I guess they're billing, right?
Correct.
How quickly is that? And who's the most difficult provider? Because we need to get to the bottom of this because we're eating into your future monies.
Correct.
Without even, is there a time limit that you're giving them? 6 months at the most, 5 months? I don't know.
Well, again, based on our current policy, it's they have 12 months from the date of service to submit their invoices.
Why can't we change the policy then?
It's a federal
It's
standard.
but we can make it stricter,
Yes, we can.
right? So why don't we make it stricter on our end so that we can make sure that we maximize the monies that we receive within that year to pay for them rather than following the federal side when we're giving them a year and they're using a year on one day, which would eat into your next fiscal year's money.
And I think this is where it goes back to what we're here all advocating about this is where we need a system in place. Again, when I first came in December of 2024, by February, March of 2025, I had to, in essence, fire our SME and PMO because there was nothing tangible
Sure.
of 12 years. And so we've been working with all of these internal processes. And again, our manpower, we don't have that capacity right now to track any of those, honestly, Vice Chair. And so this is why we really need our Medicaid enterprise system to be funded. Because this is key for us. I can honestly, and I've said this many, many times, I can tell you as a provider how much we've paid you because you're in Munis, but I cannot tell you how much I still owe you, right? Because everything is manual. It's still manual. I mean, it's very frustrating because I'm a numbers person, and to not have data like that is very, very frustrating because as a former business owner, how do you manage, right, your expenses and your liabilities when you have no control over that?
And it makes the next fiscal year much more difficult for you guys because you can't even
Correct.
project anything for the next fiscal year,
Correct.
right? So does that have to be changed just to regulations or the state plan?
It needs to go through the state plan, which is part of our regulation, yes.
So before, would Medicaid be in a position to support legislation just specifically to that section until the regulations is completed? So that we obligate these providers that they have to make sure that they send the billings in within this period so that you guys don't eat up to your next fiscal year. At least it's for a limited time until the regulations are completed, so the regulations will take over after that.
I think that's something we can sit down and consider with you and discuss more. We just want to make sure that it's in compliance with the federal
Sure.
regulations, but we're
But-
very open to any of those types of.
But for sure, we can
opportunities.
make it stricter. We can't make
Yes.
it looser, right? So
Correct.
if we can do that to help you guys out, so at least down the road you're able to kind of project your costs right up front. So when we get to the budget process, maybe we can be more creative in how to use monies and move them around to help Medicaid get the largest amount possible.
Correct.
In regards to, no, so maybe that's one thing, Chair. We can ask Medicaid. We try to get that done within this calendar year, so that you guys have something for next year that's going to be more flexible and something that's more structured in helping Medicaid project to the next fiscal year. No.
All right.
All right.
Thank
Thank
you.
you, Chairman.
Thank you, Vice. Director, so who submits the claim to Medicaid? Is it the patient or the medical provider?
The providers.
The provider says. And what is the outstanding balance of Medicaid, the Medicaid office owes to date, if there's any? I know that you guys mentioned on your presentation that about 59.4 is being expended for on-island and 16.4 on off-island medical providers.
Sorry. So, again, Mr. Chair, just like I was just saying earlier, you know, we can tell you how much we paid you. It's very, very difficult to have a real hard number or even an accurate, I would even say within the 80 percentile
Okay.
of accuracy of how much we owe, you know, was remaining because of our systems. But just conferring with Tenta, just on preliminary numbers, we're looking at still approximately over $70 million.
70 million. And how's my next question, how is the reimbursement and payments with the off-island providers? Is that also within a year? Are they very fast in submitting claims, or it takes a while? I mean,
Yeah.
it's noble to ask this, right? We're dealing with
Correct.
foreign countries, right? And it's not the same as medical clinic here that we can knock on doors and like, hey, is there any claims from our clientels? We're speaking about off-island foreign.
Correct.
How's that going about with your office in claims?
Sure. So just to clarify, our off-island providers are Guam, Hawaii, and California. Currently, we do not have, we are working on policy with the federal government on foreign providers, which is in the Philippines, South Korea, Taiwan, et cetera. That's not completed yet. It's in the process. But in regards to off-island, unfortunately, because we don't have a system in place, electronic system in place, our off-island providers, the hospitals, such as Rady's Children's Clinic, they have to send literally boxes of invoices to us. And I can tell you, from our old office up in Capitol Hill to where we're at now here in Garapan, or down in Garapan, unfortunately, some boxes got lost in transit. And so how do we reconcile that, right? And so it's very difficult. Again, our goal as part of our MES system is not just eligibility and enrollment. We want providers to be able to enter their invoices and their claims within a system. So they don't have to send us literally boxes and when I say boxes, Chairman, I'm talking about boxes. I mean, banker boxes. And it's like, wow. You know, and that's probably only sometimes for Rady's Children's Clinic for 1 month of invoices, we have about a dozen boxes. And there's still boxes that get lost in transit somewhere. And so, again, we can't tell you how much all of that is worth, right? And
Okay.
But yeah, so unfortunately, they do have to send it through snail mail.
And how long does that process take? Like
So
months to just
yes,
mail those boxes over for your team to start processing?
yes, and then of course it's the reconciliation. You know, because they're following up with us. Hey, did you receive our boxes? And there was moments where it took a month, some where it took 3 months. And again, like I said, in between, there's boxes that got lost, so not all their invoices were submitted or received by us. And so it's a back and forth. I can tell you, though, to the committee, that even for off-island, we are at least within 18 months of reimbursements. From about 3 to 4 years, we're down to 18 months. I really want us to
Nice.
close that and be in real time.
Thank
And the
you
only
for
way
that.
for
We
us to get there
congratulate
is
your
through our
team on
MES
that, yeah.
system. Correct.
Thank you. Let me ask just two more, and then I'll open it up to the other members. There's still a lot of questions. So my next question will be, has Medicaid office ever requested for a matching fund waiver in the past, if ever requested? Is that something that has been done in previous years?
In regards to the federal matching
Local match.
or local match?
To waive the local match.
Oh, to waive, I think we always do. The same with the current 21.4 that's being considered in the U.S. Congress right now. We have asked and requested for 100% federal match. We are also working with the Congresswoman as well as the U.S. Senate Finance Committee and the U.S. House Energy and Commerce Committee for an appropriation of about $73 million additional on top of the 111 million for next fiscal year at 100% match also to help us catch up with things, pay off, hoping that we can extend the disaster services going into next fiscal year.
Right.
So yes, we always do. We've asked it for our mess side because it's a 10% match. And
Right.
unfortunately, our CMS, which is our federal partners, they say you could put a request in, but because it is a statutory issue and it's a law, it needs to go through Congress versus our
Right.
federal partners.
So are we still, is your office still working with our delegate in trying to, I know that we've been successful with the percentage of matching, right? We used to be at 65-35 at one point. Now we're at 83-17. It would be nice if we keep asking to lessen that local match, maybe 90-10, only because of our fiscal challenges right now here in the Commonwealth and all that. But that's something that history tells us that we've been fighting for it and we've been granted over the years. My take is like keep fighting for it until we get to
Yes.
100%. I'll now open it up to other members. Recognize Representative Angelo Camacho and then Madam Floor Leader.
Thank you,
Please.
Mr. Chairman. And then, so just question, just going back to the additional 21 million in disaster-related funds. So I think I heard you clearly, that it is not sure yet if it was going to be 100%
Correct.
matching, covered. So, for instance, it's not 100%, what would the local matching percentage be? And this is just for the.
For approximately 4.3 million in addition to what we're requesting now, yes.
Okay, so that's for the additional 21.
Correct.
So
If
we're
we do
looking
not
at-
get the 100% federal match,
And then we're looking at
4.3 million.
4.3. Wow. Okay.
So just give you context, we were in communication. We had Zoom meetings with both the U.S. Senate committee and the U.S. House committees. And that was always been one of our main ask is we need to make sure it's 100% federally funded, right? Or matched. And unfortunately, when it passed the Senate, they didn't put that language in there. And so we're now working with Congresswoman King Hines because it's up for vote this month, I believe, in August. And so they're trying to make sure they put it into the language so we get that full matching.
And so that's just specifically for the disaster related.
Yes.
Behavior. Like therapy and
Yes.
whatnot. Okay. So you cannot use that for any other like regular checkups and
No.
no. Okay. Thank you. And then my next question would be, how much Medicaid funding is actually spent per individual recipient? Just an average, maybe, cost per beneficiary, including the maybe annual and monthly, if you can answer it.
Those are questions I've been asking myself since I came on board. And again, because we really don't have, honestly, we don't have a system, any system. We're just using Excel to track.
But there's
That's
like
it.
a
And so
rough-
we can't even extrapolate any type of information or data to get to, because that is one of the things I want to be able to provide to you, to this body, is that what is it costing us as taxpayers, right? As a legislative body per individual when they receive care. And unfortunately, I apologize because we cannot provide that data.
Okay, yeah, and the reason why I asked that question is because with the anticipated furloughs, right, we want to kind of get an estimated number of how much we're looking at. And of course, if we can find that additional 2.2 million to secure that additional 11 million, it would be great. That'll basically cover the, whatever furloughs. We don't know how many people are going to be furloughed, so.
Correct.
I think it's important to kind of get a rough estimate just to kind of see where we're at, right? But yeah, that's the only questions I have so far, Mr. Chairman. Thank you. You.
Sorry, can I just add,
Please
to add a
proceed.
little perspective? It's not average, but I personally have seen that we spent about $1 million on one patient in 1 year, just for cancer treatment in Los Angeles.
We do have some preliminary numbers, just to touch up to that. So as an example, we one of the things that I did request from claims, and it took about almost a month just to try to pull that data off. But in a 3-year span from fiscal year 22 or 21, 22, and 23, the CMA spent approximately $24 million on cancer treatment for approximately 16 people. It gets worse than that. So out of that $24 million, we broke it down. We spent approximately $14.5 million on oral cancer alone for 16 people. So we can put that into perspective. You take, 16 divided by, 14.5 divided by 3, it comes out to approximately almost $300,000 to $400,000 per year per person for oral cancer treatment alone.
Thank you for that
Sorry,
response.
Mr. Chairman, and we're talking 23,690
Individuals.
individuals right now. Okay. Thank you.
And that number, according to the presentation, is bound to increase by 3%. So, Madam Floor Leader, please.
Thank you, Chairman, and thank you to the Medicaid team for being here. Sorry, I just had to catch my breath there because that's a lot
Yes.
of money. And for 16 people, and I don't even know where to start, honestly. But obviously, there is a systemic breakdown when we have, how many providers did you say? On island?
40.
And how
approximately
many
40.
off island?
17.
Okay, but CHCC is the primary hospital, correct?
Yes.
Okay. And the largest single Medicaid provider on island. How does the claim system interface with the Commonwealth Healthcare Corporation's billing system? Is the submission and adjudication process fully electronic, or does the CHCC Corporation still submit paper claims or use manual process for any claim type? Yes or no?
You want this one?
So there's two parts to reimbursing CHC. One of them is the CPE, in which we pay them on an approved interim estimated cost of care for the current fiscal year. Later, it gets reconciled. So we don't actually see real-time claims.
Okay. Which is why you're here, because you're advocating for your system, is that right?
Yes.
Okay, and that's an injustice because it's taking so long, and that's always been my problem. And it's not for any of you guys, right? It's just access, service, which is what the government should be doing. So let's follow up then. Centers for Medicare and Medicaid Service Disaster Relief State Plan amended on June 30, 2026 was approved, is that right?
Yes.
Which is part of this disaster component that we were talking about, provides interim prospective payments to providers disrupted by Typhoon Sinlaku, but expressly excludes CHCC from those interim payments. Is that true?
Yes.
And what is the rationale for that exclusion?
It's because they were currently paid.
And how has the Commonwealth Healthcare Corporation been managing its Medicaid cash flow since the typhoon?
I cannot talk on behalf of CACC in regards to that.
But you guys work together, isn't that right?
In
Supposed
regards
to?
to reimbursement, yes,
Okay.
but not in managing how they run their funds.
It wasn't really about managing their funds. It's going back again to the system in which that you don't have what you're advocating for to keep it so that our numbers are right, our advocacy for reimbursement is correct. Because right now, then, if we don't have this system, how do you guys handle fraud claims?
Exactly. And so that's why we're unfortunately, we're for that. That's also why we had to establish two new offices within the Commonwealth Medicaid Agency, which is, again, the Program Integrity and Oversight, which includes our audit and investigation.
Okay, so have you had any fraud recently?
We have potential that are being looked into.
And how long have you been looking into that?
at least during my time, this past maybe 20 months.
20 months. And it takes how long to get paid?
Right
About 20
now,
months?
about 90 days.
90 days, okay. But for fraud, you guys have to go through this process for 20 months.
Again, everything is manual.
Okay,
And I know it sounds funny. It's just that means we have to manually look for files.
Again,
yeah,
I don't think it's funny, and pardon me
Yeah.
if I was being a little cynical, right? It's an injustice.
it is. Yes,
Because how do you improve service without knowing the data,
correct.
right? So the Commonwealth Healthcare Corporation's billing system and the agency's claim system are two separate government entities, which you just mentioned there, correct? Is there a formal operating agreement, data sharing agreement, or interoperability agreement between the two agencies governing the exchange of claims, eligibility, clinical, and billing data?
From my knowledge, yes, especially amongst public health and other parts of CACC, yes, we do.
And what other parts of those divisions are there?
Things from WIC,
Tobacco?
I believe so. Gosh, sorry. But
Okay.
Yeah.
So is
CGC,
there-
etc.
So let's break it down. Is there an operating agreement?
Between us and CACC?
Yes.
Oh, yes. Our
Is there a
contracts, yes.
data sharing agreement?
Yes.
Is there an interoperability agreement?
What's that? We, unfortunately for that part, because we don't have a system in place for that, no, we don't.
Okay. So you're familiar with Public Law 2128, correct?
Yes.
And that's supposed to set the standards, which is why you're here, because now you're advocating to comply with Public Law 2128 in terms of the system. Is that right?
Yes.
Okay. And a lot of this, again, is going to go through this, how you need the people so that the system works, correct? And this is why you're supporting scenario 1. Is that right?
Yes.
Okay. So walk me through the current end-to-end claim process for a typical Medicaid patient at either the CHC and out of state or out of the Commonwealth, from the point of service through eligibility verification, claim submission, adjudication, and final payment.
I will defer to Hilma in regards to at least on the eligibility. We'll focus on off-island, on what's the process for that. Because there are processes in place for that. You want to share? Yeah.
Real quick, you don't have to go through I'm just trying to see if there is a system in place. And
Okay.
how having this MIS system or the system internally is going to help you do your job so that we can better serve.
Okay, so right now, for example, he said to focus on off-island. If we have a beneficiary who requires, medical treatment that is not available within the CNMI, they're required to go through CHCC's Health Network program and through their committee for approval of the services. And then we also verify, then they have to verify, are the services covered? Is it something that is covered by our program? And they are, mostly familiar with what is covered and what is not covered. Okay, and so then once they have the referral approved, they are the ones who do the logistics. They communicate with the providers in the U.S. And once they find an accepting provider, the accepting provider, if they are not enrolled with us, they have to, if they do not accept our payment rates, our reimbursement rates, they will usually want to enter into a letter of agreement with us so that they can impose their rates. And for each entity that we have to provide services for the patient, we need to do verifications to see that they are enrolled in the Medicaid program in the state in which they will be providing services. We have to also verify that they are not on the OIG exclusion listing. We basically have to verify that they are eligible to enter into an LOA with us and provide the services, not just the facility, but even the individual provider.
Okay.
Yeah.
And I'm assuming that's all manual?
Yes.
So,
And that's not even getting to the services and the claims.
all right,
yet.
so tell me, if you had this system, so tell me now manually, what's the turnaround? What's the timeline? What's the turnaround?
I can't speak for the referral process at CHCC, at HMP. But for an LOA, it could be anywhere from 2 days to a couple of weeks, depending on whether the requests are complete. They're fully documented, information is correct. And then after that, it's again up to HMP to get the patients there.
But if
to
you had a
seek
system
treatment.
such as the one you're advocating for, how fast could that be?
Well, basically everything, for the referrals, CHC could verify eligibility, they could verify the services, the benefits, and, do the claims in the system.
Okay. So much faster.
Yes.
Yes. Can I just add some context to what you're
Sure.
saying? Because I appreciate that. Because when I came in, at least for our off-island providers, I was given a stack of LOAs, contracts for off-island providers that I was asked to sign. And so one of my questions was, what is this? It says, these are for patients. We just need to sign it for, I said, okay. So I took one and I said, how much does this cost us? And we didn't know. And so that was one of the first things I did internally was, no, if in order for us to balance, we only have X amount of dollars. If this care is going to cost us 10 million, how can we afford the rest? And so I had to put in processes, temporary processes, until we finalized things, to at least review, one, make sure that they were beneficiaries. We found LOAs. These are our contracts that bind the CMA to payments of patients that were not Medicaid beneficiaries. And if I signed blindly on this would be a commitment that the agency would have to pay,
Yeah.
right? And yet they weren't Medicaid beneficiaries. That's just one example, and there's more.
That's a
But I just
horrible
wanted to show you
example.
that that's what I was entering into 20 months ago, and that's changed now because we've actually put processes in place to ensure fraudulent, claims and things like the requests.
Right, and I think that's a valid question to ask, because once you have more fraud than claims, that's going to be a problem. We lose more of the federal money because we can't seem to manage our house internally. And so the system, is it operational already or not yet?
No, we just closed the RFP.
So you
it's
have
working through the
decided, who is
procurement.
the vendor?
I can't say until procurement announces that.
Is it a local or off-island vendor?
Local.
Okay. All right, so the fiscal year, and I'm getting to this because you expressly said that you are still using Excel spreadsheets because this system does not exist. Is that correct?
Yes.
So you're not even federal compliant, is that correct?
Yes.
Oh, boy.
Well, we're using Google Suites.
So one of the, okay. So here's my follow-up then to that. There are other service providers outside the Commonwealth health system. And I personally don't go to CHCC unless it's an emergency. I feel as a member of this community, I should be given the right to decide where I want to go as far as my health. So one of the problems that I found, and this is personal to me because my mother had to go to CHCC for the services. And it was just an experience. It's a roller coaster ride, both emotionally and physically and spiritually, okay? But one of the things that really disturbed me was that this system does not talk to each other, right? So if my mom decided, I don't want to go to CHCC because I want to be able to go to, let's say, Isla Health Center, that's a right. The government should not tell people where to go. So she went there as a choice to better manage her health. The problem I was having was that she had to pay 25 cents for the paper to be transmitted over to hard copy. This is what we're talking about. But the simple fix was just let everybody talk to each other because they should understand HIPAA rules and laws. Is that correct?
Correct.
And certain things should and should not be given and entered into the system. Is that correct?
Correct.
But in terms of paying and drawing down on the subsistence, right? should be there, right? Because now we have to file everything manually. And I'm glad that our chairman for health and welfare is here, because this is a problem that we've been trying to fix. So the same should apply then for overseas.
Yes.
Instead of going in and saying, okay, your file got sent, I literally have to take one luggage with me and give it to them, hoping that not one piece of paper is missing, because that could be detrimental to a
Yes.
person's life or a person's death. Is that correct?
Correct.
So once again, for the record, sir, how much are you asking for to get this medical system up in place so that, number one, you will be in compliance with the federal mandate, and number two, most of all, more importantly, in compliance with Public Law 2128? System and service, that has to go together. So you will need people, correct?
Correct.
And how many were you asking for?
On this time around, we're looking at 20.
Okay.
So,
And
okay.
scenario one says you have a decrease of 7 NOPs. Is that right? In scenario one? Unfunded with a decrease of 7 NOPs. Is that right, Cam? Is that correct? On your budget analysis? The revised, right? Yeah. Is this correct? Okay, so we see a decrease of 7. Would that be detrimental to the service under the system in which you're asking for?
Actually, just to make clear that NOPs, so they're in the first original submission for the budget, scenario A has 2 types of NOPs. One matched at 50%, which is the 27, and the MES is the 20. So in the most recent revised budget, to reflect the governor's alignment, we removed the 27 completely, so we do not need NOPs for that. We're just sticking to the 20 for MES.
Okay, so no FTEs,
Yes, for MES only,
just for, so how many FTEs do you need for MES only?
20.
Do you have your standard operating procedures already set in place for this MOS and your flow?
We are actually in the process of working on that. And just to add to what you were saying in regards to all this health exchange, what we call health information exchange, we're actually very happy. We just hired Jeremiah Beneventi, who is going to be our HIE, Health Information Exchange Coordinator. So that's actually one of his overall goals, is to help ensure that the information between clinics off-island and on-island are consistent. That's the overall goal. And so hence why we need to make sure that we support our MES systems, our division, to ensure we get those systems in place, because we start off with eligibility enrollment, then we're going to go into claims, then we're going into provider enrollment,
Right.
and et cetera, and then, of course, health information exchange amongst all of that. So,
Okay, so yeah,
yes.
that's the system. And this would be the 7 that would be, 20 that would be locally funded, is that correct?
Yes,
And
at
what are
10%.
100% local, is that what you said?
At 10%,
At 10% local.
yes.
And that is, yeah, I know that. And how much is that exactly? I want to hear it from you because it's on record. I can easily go to my paper, but if it's on record and you state it, then that means different. How much is that in terms of numbers?
For the MES system, 10% local match, our total asking is 555,891.
So let's say 600,000.
Sorry, slightly short. 550,684. I was
Okay.
reading wrong.
And this is locally funded for the FTEs needed for FY 2027 to support the MIS system. Is that right?
Yes, inclusive of operational match.
Inclusive of this, 500,000.
550,000 for operations.
And you would be able to conduct your entire service through the system, is that correct?
Yes.
Ms. Cruz, Ms. Tenta, you don't look like you're
No, we both said yes. Sorry.
Yes. I was looking to see, just to inform you.
Okay.
That represents 6 million in federal funds that we will receive just for the MES.
Okay, so my last question, so that's just for the local, for the MIS system to improve service, which is so important to our community because it's our health. So are there any repercussions under the federal side if this MIS system is not in place by fiscal year 2027?
We just, my Vince and myself just came back from the Medicaid Enterprise System Conference in Portland, Oregon, just last week, and we did meet with our federal partners, and that is actually one of the things they did warn us about, is because 12 years have passed and nothing was utilized and done, and that if we don't move forward, we are subject to a possibility of losing federal financial support for our MES system.
All right, but does that impact the service then?
It will, because
By how much?
the administrative burden is going to just increase. I can't even extrapolate the amount.
Okay.
I mean, because now
So
people
we
still
won't be
have to-
covered? Maybe
Correct.
not?
Correct.
And you need to say that on record, Mr. Cruz, because people need to know what is at risk. This body has to decide whether or not to agree with the governor's proposed scenario or find another way, right? And that's important because the claim is that there's no money. But we know that we've been getting federal assistance. And have you brought this up to U.S. Delegate Kim Hines? Of the possibility, knowing the economic climate right now, and if there's no local fund to support the 550,000 in which you're asking to successfully run this MIS system, has she been involved in this conversation?
We just had that conversation just last week with
Okay.
the feds, so
Okay.
that is one of, and then of course this week is the budget. So
Yeah.
these are things that we have been communicating and will continue to communicate with the
Please.
delegate's office.
Thank you. And I think that's it for me. It's all about the system. You're here advocating for the importance of the system in itself to be in compliance with Public Law 2128 and the CCFR, in which you are mandated to have, because for 12 years, we could not meet the ask of the federal government under the law, which was to have a system to safeguard the U.S. federal tax dollar. Right?
Correct.
Okay, thank you, Chairman. I yield my time.
Thank you, Madam Floor Leader. Any other members who ask questions for Director Cruz and his staff? Recognize Representative Ralphie Wong.
Thank you, Chairman, and thank you, Mr. Cruz. In the event that scenario one does not follow through, how would the medical or Medicaid make up for the $550,000 that needs to, cover?
So, like we were just mentioning, if scenario one at the 5.6 million is our bare baseline, that means we'll be able to cover the minimum health care coverage for both our off-island and on-island providers and beneficiaries. Yes, we will be giving some money back if we don't have the full funding of 7 point some million. If we go below scenario one, we are very afraid that what may have happened in 2023 or so, where we would have to stop services, would most likely happen again.
Okay, so
Because we won't not be able to afford additional health care
right.
coverage.
So, but with regards to the law that needs to be in place, and you need, I guess, 27 employees. Is that what?
20.
20. So how would that impact your additionally to what you currently have right now?
So I'll turn it over to Vince. Maybe you can share about how the staffing will support the MES system.
Yeah, we're talking, this mesh system is, like he said, it's not just one system. It's gonna be modular, right? We're gonna have our eligibility and enrollment, we have claims, we have provider enrollment, we have, audit, we have a lot of things that needs the support of all these employees that we're asking for. But of course, even if we don't get any money to even build the system, which is, for the 500,000 that we're asking, we're gonna get $18 million in 3 years. Right, so, we're basically, and the MES division is 90/10, so we're getting a 90% discount for them to pay for our system that the law has required us to have. So, with that, I think it's, the 20 employees is, because it's not a little system.
Right.
We're gonna need all of it.
Okay, well, because I think some of us members are looking now, like, for example, the shortage of over $1 million for retirees. We're looking at tapping into the delegation funds to ensure that. So now we're gonna ask our chairman to also consider looking at delegation funds to at least cover, some of this. And that's a serious discussion because we're really short and we're going beyond the budget now. So we're looking at the poker fees and the e-gaming fees to try to cover or to ensure that we can manage to at least for this year to cover the request, especially we still have PSS asking for $1 million. Now we're seeing now the additional $500,000, assuming that we all agree on the scenario one, and then covering the additional 500,000 and I guess going deeper in our pockets and looking for that 500,000 in the delegation level. So that's something that we're going to have to sit down with other members and seriously look at how we're going to manage to cover all of this so that our people don't lose out on this benefit. So,
Right.
yeah,
And
it's going to be a tough one.
if you don't mind, Congressman, if I can just add to what you're saying. So, again, one of the things with Medicaid and what I envision is also supporting those exact same agencies, such as DYS and also PSS. We have funding through our CHIP to be able to support some of the services that PSS provides and DYS provides to those that are under the age of 19. And as long as they're, of course, Medicaid beneficiaries, which majority of those that they service are Medicaid beneficiaries. But with putting them as a potential CPE, Certified Public Expenditure, like CACC, we should be able to help offset some of their budgets with that. So we've been in discussions with DYS, we've been in discussions with PSS. We're just working on the details of certain data and processes, things like that. But we're hoping that by sometime next year or end of next fiscal year at least, we foresee having PSS and DYS as potential CPE recipients of funding from Medicaid. So now we can also support and offset some of their costs in regards to that. So we want to be part of the solution and not a problem.
But we also understand, and also when we dig deeper into SNAL, now we're asking the AG to come in and say, well, is this only for the for Saipan only? And we have to start separating the islands. So we don't want to get into that. We want to make sure that you cover one, you cover all, and not go into the separation of each island. And that's when it gets really, very sensitive. Exactly. But yeah, that's something we're looking at now. It's up to the delegation if they want to explore additional using delegation funds for health. So that's up to the members now. Thank you, Chair.
Thank you, Rep. Yumo. I just have just about 2 or 3 questions, Director Cruz. I ask for your indulgence if some of the members have asked already, but based on the governor's budget submission, specifically on the original submission of scenario one, approximately 105K was allocated to Medicaid enterprises system for personnel. Furthermore, we noticed that the specified amount covers 10% of employees' salary. So I'm assuming that the 90% is federally funded, is that correct?
Correct.
Okay, and we further noticed that there are numerous vacancies within this budget activity. Has any of those vacancies been filled as of yet?
Two have been
So
fulfilled.
we still have a vacancy of about approximately 14 or
Yes.
that have still need to be filled. So how is the agency working on filling this? I know that it's budgeted, and how long has it been taking the agency to fill these positions?
So, of course, we've been working with OPM on trying to reach out and increase our number of potential candidates. But one of the other things that have affected us is because of the reduction of our current fiscal year budget from approximately $6 million to about 4.4 now.
Okay.
That has truly affected our match for those positions. So at the moment for this fiscal year, we're not able to match those positions. Hence why going into next fiscal year, we should be able to solidify those positions and be able to fully fund those, both local and through federal match.
But these vacancies, these are locally funded, right?
At 10%.
At 10% only?
Yes.
I see some are at, okay, so the 10% and the, of the, like some positions are at 35,000 per annum, 53, so all of these are 10% of local, right?
Correct.
Okay. Thank you. So let me recognize Madam Florida for more questions.
And thank you, Chairman. I know that we're heading into the seventh inning stretch here. So I like this idea of this question that Rep. Yumo was posing earlier. And yes, it is sensitive when you're talking about the three islands, but really nothing separates us. It's CNMI. But let's just start from the mayor, because when you talk about mayor's budget, you have three mayors, when we really should just have one mayor. And all these other offices should help each other, right? But that's not our reality, and I just wanted to put that out there so that, you know, there's some humor into this, because now we can talk about cost savings, which is our big problem, because the economy was great before. It's not great now. Therefore, we're having these discussions with the governor because we have nothing to help support when there's no new economy pumped into our community. We're recycling our paycheck. We are recycling everyone's money. It just keeps going like this, back and forth, back and forth. So would it help, and I have not seen CHCC's budget, but they get a lot of funds. I've never seen anything on their billing. Would it help you if we were to figure out, or maybe the agency can figure out, and maybe talk to our chairman over here, because billing is an issue. How you guys can get together possibly, because it's a state hospital working with the state system that should already share billing. I'm not talking about patients. I'm talking about numbers. I'm talking about service, the impacts of that. Maybe that's something we can, figure that out, because if it's billing, it's not like you're taking let's say a psychiatrist from CGCC that might have 100% grant support. You know what I mean? You're talking about data entry. But I'd be curious, Mr. Chairman, if you would be so kind to have that conversation with Ms. Munya and maybe your board, because if we need to help each other now, the time is now. When you're talking about billings and system improvement so that service can sustain. I think those conversations need to happen, because if there's a way where we can help you through an organization. I'm sorry, how much was CHCC was only asking for HMP, is that right? Do you tap into HNP, Mr. Cruz?
So the way HNP is, again, all medical referral go through HNP for us to, but it works on a reimbursement. So CAC would front the payments for off-island travel as well as the care, just off-island travel, accommodations, et cetera, ground transportation, and we would reimburse for all of that.
Okay, and now before I close, because we need to leave soon, you mentioned that, so can you give me the data on how many people HNP served this, or last fiscal year?
Do we have the data? No, unfortunately, we don't have that data at the moment.
Okay, but you were saying earlier that 16 people for cancer patients, total of 16 within our community. It doesn't matter to me what ethnicity they were.
Correct.
They were also, I'm assuming, part of the HNP, right? Majority of them.
Yes, if they were off-island and Medicaid beneficiaries.
Okay, so they have to have both.
Correct.
All right. And we spent an average of $24 million, is that what you said?
Approximately 24 million over 3 fiscal years on cancer-related services, and specifically 14.4 million on oral cancer over 3 years.
Okay, all right. So yeah, I really do think that the healthcare system in itself should really sit down and start collaborating with you guys in terms of the billing on the system, because if we can take some of that and share that resource with you, it makes more sense. And I don't like when they have to come to the legislature and say their life depends on you. It's true, but their life also depends on a service provider, such as the hospital, such as you guys, such as like DPS, healthcare, safety, education.
Correct.
That's it. And if we can't even meet that in any scenario, that's an injustice, period, for me. Figure out a way to talk to the chairman of this committee, but also reach out to Ms. Munya. I'd like to hear what she has to say about sharing costs when it comes down to supporting the system for MIS. Because I think in the public law, 2128, it's very clear what that system needs to entail. And I think you can leverage off CHCC. Thank you, Chairman. I yield my time.
Thank you, Madam Floor Leader. Are there any members have questions for Director Cruz and his team? Just one question, last question, Director Cruz. I know all these grants, right, that were given to Medicaid agency office, part of it is also inclusive of the COFA citizens, right, or people from federal state. There's no separate grants that you get to support these citizens, right? Everything is part of it, the grants. Are there any separate COFA funding that is given to your office to assist its citizens?
Yes, we do. So actually, part of the 111 million includes the 10 million allocated for COFA.
So the 10 is added for COFA?
Yes, and that's part of the 111 million that we've presented.
Okay, so it's all
Encompassed.
inserted in encompasses, okay.
Yes.
Thank you. Members, any further questions? If not, I'd like again to thank you, Director Cruz, on behalf of the Committee on Ways and Means. We have heard a lot, and between the two scenarios, we hear you clearly that it's scenario one, that is what you are appealing to this body, and also if this body can find an additional 2.8 million so that we can take advantage of the full ceiling of 111 million that is granted for this fiscal year. We took notes on that, and I want to thank you and your team for coming before this August body, and I'll give you the last words. If you have, you may have, you have the floor.
Thank you. Again, I really appreciate the time, Mr. Chairman, as well as for the committee. And just to remind the committee that, again, our goal here are to be, good stewards of the public funds and to be aware of what you are facing. And that what you are investing into the CNMI Medicaid agency is exactly that. It's an investment in the agency, but trickles down and affects our providers, the economy, and most especially the people that live here in the CNMI. And with 56% of our population that we service, I think this is a critical need, especially as we anticipate potential issues going into next fiscal year with additional reduction in hour, the furloughs, et cetera, that I don't think this is the best time to, there's never a best time, but to reduce healthcare coverages for our people. And so again, I thank you guys for your time and for considering our proposal.
Thank you, Director Cruz and your team. With that, we move further down on our order of business. We're now on item 6, announcement, and the chair would like to announce to the viewing public that tomorrow at 10 a.m. we do have a Saipan and Northern Ireland Legislative Delegation session at 10 a.m. So with that, are there any announcements by the members? Ready? With that, we move on our last order of business, and that is item 7, adjournment. And at this time, the chair now adjourns this Ways and Means Committee meeting. Thank you, members, and to the viewing public.